All right, good afternoon or day, everybody. Whatever day it is that you're watching this on. Just want to give a quick introduction. We're going to get going here. Obviously, this is going to be a new way for us to get our learning in, so we just want to make the best of it. Today, we're going to be going over EKG basics class. So we're going to start off with EKG components. I broke it up into two classes. So first, you go through this class, which is going to be EKG components, and then the next class or PowerPoint that you'll be watching is going to be EKG interpretation. And again, we're going to be keeping that super basic and relevant to what we're doing. Quick introduction, you guys know me, David Gonzalez, just another paramedic here. So let's go ahead and get going. Some of the objectives that we're going to be going over is going to be basic cardiac structures. We're going to follow that conduction through the heart, see where it goes, where it ends up, as well as EKG electrode placement. And then we're also going to review the electrical conduction through the heart. We may get these out of order here in just a minute, but it'll be fairly easy to follow along. So first off, let's talk about the basics of cardiac muscle. We know that cardiac muscle is unique in that it's unlike skeletal muscle or other different types of muscles that we have, right? It has three unique characteristics, those being automaticity, conductivity, and contractility. And when we refer to the cardiac muscle itself, we're talking about the myocardium. So myo meaning muscle, the cardium relating to the heart. So obviously, in this case, we're going to be talking about the myocardium. So let's break those three different things down. So let's go into automaticity. When we say automaticity, it means that it can self-initiate conduction, and this is one of those characteristics that heart cells or muscle can do. It has the ability to initiate its own conduction. Generally, this is going to be done initially at the SA node, and another neat thing is that all cardiac cells have this ability, and we'll take a look at some pictures, but we know that if it doesn't work for some reason, the SA node is having issues, it's just going to move on down the line, and eventually one of those cells, one of those next cells also has the ability to initiate the conduction, and we'll look into that just a little bit more. Conductivity, so when we talk about the conductivity of a cell or its ability, mainly means that it has the ability to move electricity, or in this case in the form of ions. It has the ability to conduct and move those ions from one cardiac cell to the next. And when we're talking about these ions, this is mainly going to be seen in the form of sodium, calcium, potassium, and the influx of these, that movement in and out of the cells, is what causes that contraction of the heart, which brings us into our next point of contractility. So contractility is going to be directly affected by preload. Starling's law or mechanism is something that we can all look into afterwards, but basically what it says is that if we can stretch the myocardium further, it's going to allow for the myocardium to squeeze harder. Basically, same as a rubber band. The further back we pull it, the further it's going to shoot, right? The further we stretch it out, the more tension it's going to have on it. Same thing goes here. In the case of the heart, contractility is directly affected by Starling's law. Now, there are also other things that can affect the heart's contractility. For example, if a patient's taking certain types of medications, if they're taking something like, let's say, labetalol. Labetalol is a beta blocker, and it's going to slow the contractility of the heart, so it's going to slow the heart down, and it's not going to pump efficiently. Whereas we can also affect it ourselves when we give the patient medications like epinephrine. we're affecting how strongly that myocardium is going to contract. So those are different things that can help or hinder the heart's ability to contract. And the other thing is fluids. So fluids, again, directly affecting the contractility when it comes to Starling's law. More fluids circulating, we're able to stretch out that myocardium a little bit further, help the heart contract a little bit harder, get some more fluids or pump out of the heart, right? So let's take a look at the pacemaker. When we talk about the pacemaker, we all know this as the SA node. The SA node is what is known as the pacemaker of the heart, and it is the primary pacemaker. Its setting, and we say that in quotations, right, is normally set between 60 to 100. Anything above that is going to be faster tachycardic. Anything less than 60 is going to be slow or bradycardic. And the neat thing about the SA node is that it's directly affected or innervated, so it has nerves from both a sympathetic and parasympathetic nervous system. So these can actually determine the pulse rate at which the heart should pump at. So, if we think about it, if somebody goes out for a run, their sympathetic nervous system says, hey, we need to pump a little bit faster, right? Whereas if we're just relaxing, sitting on the couch, having some dinner, it knows that it doesn't need to work as hard, right? Now think about somebody with a heart transplant. Somebody with a heart transplant has a completely foreign heart placed inside their chest cavity. Now the nerves aren't necessarily reconnected into the heart. So is this person going to have, again, the ability to tell its heart to pump harder when it's experiencing some kind of distress, or when they go out for an exercise? No, actually, they have to circulate certain hormones in order to get their heart to pump at the appropriate rate. So just something interesting to think about when we're looking at these different types of things. When we're looking at the pacemaker and we're looking at the heart, well, what kind of things might be affecting it? The node or the SA node is basically just a group of cells. It's not necessarily one single cell on its own. It's actually a group of cells, generally in a crescent shape, and it's located in the right upper atria, where the vena cava meets the right atrium. And this is going to be, again, primarily responsible for initiating that impulse, starting that conduction through the heart. So here's a good image for us to look at. So what we see is that at the top, we see that the SA node depolarizes, or it initiates that impulse. Then that electrical conduction flows through its pathways, so it flows from cell to cell. And this is what causes the contraction of the myocardium. So the flow of those ions that we talked about earlier goes from cell to cell as they connect, and as it's moving through, it causes the contraction of that myocardium, or that heart muscle. The heart muscle then contracts, and as we know, the heart being the pump that it is, the atria contract, then the ventricles contract, and causes that pumping effect. So we can see here at the very top, let's just identify these structures real quick. So right around here, this is what we see, or this is what we know as the SA node. Then we have these other interatrial pathways. So what happens is it starts that conduction starts off here at the SA node, flows through the myocardium, through the atrial myocardium, flows through all its different pathways, and then it comes right back to this next little spot right here. And we'll get into what that is. But we can actually see that it has lots of different pathways, but they all kind of have to reconvene and come to this one site, which is what we know as the AV node. So once it reaches the AV node, so let's identify that structure. So this now is the AV node. So the SA node started that conduction, flows through its pathways, and then comes right back to that AV node. the AV node actually slows the conduction there. And what this does is it allows for the filling of the ventricles. Now, with that being said, we said earlier that if the SA node for some reason didn't start that conduction, well, the neat thing here is that the AV node is actually kind of slowly charging itself just in case that conduction doesn't get from the SA node down to the AV node. The AV node is going to be ready to fire off at its preset rate, just in case the SA node isn't working properly. Now that's just kind of a backup system that we have. So, but in this case, once that impulse reaches the AV node, it slows the conduction, allows for the filling of the ventricles. The next little site that we can follow our electrical conduction through is going to be the His bundle. So let's talk about that. So the His bundle is going to be right in this area. So we have the His bundle here, and it starts at the superior septum. So we can see that the AV valves actually act as insulators, because once the conduction of the heart goes through the atrias, reaches the AV node, there's actually no way that it should be getting through, right, in normal pathology. So there shouldn't be any kind of electricity passing through these valves. And the reason being is that these valves actually act as insulators. They act as insulators so that we only follow a certain pathway, right? SA node, these pathways, AV node, and then down into the His bundle right here. After we hit the His bundle, this then bifurcates. So it has two pieces, what we call the right and left bundles, right? So we can see that on this side we have patient's right, so the right bundle, and the left side we have the left bundle, and this just travels down the septum of the ventricles. And these are actually just thick bundles of Purkinje fibers. And these Purkinje fibers are actually attached to the papillary muscles, so let's identify those. Papillary muscles are what we see right here. These papillary muscles right there, we have the same thing going on the other side. Those papillary muscles pull the valves open, so they allow that blood flow from the atria to the ventricles. That's what the papillary muscles do, opening up these valves. And then we have the terminal branches of the bundle branches. So these are composed of, again, now rapidly depolarizing Purkinje fibers. So let's identify those. So once we get down to the bottom here, these are now our Purkinje fibers, and they wrap around the outside of the ventricles. Again, the ventricles are very large, so we see a lot of electrical movement. Now imagine this wrapping around the whole heart, right? So not just on the sides laterally as we're seeing it here, but imagine the whole heart just being circulated by these rapidly depolarizing Purkinje fibers. And again, that causes that contraction of the ventricles, then pumping blood out to the rest of the body. All right, so now let's see what we see on the flip side on our EKG. What is it that we're actually looking at? Well, let's start with this first one, the P wave. So the P wave represents atrial conduction. So it doesn't necessarily mean that the atrias are contracting, but it does mean that the electrical pathway is initiating where it should be, right? So it represents that atrial conduction, and it just means that the atria's electrical system is working appropriately. So that first upward deflection that we see on an EKG is what we can identify as a P wave. And a P wave precedes a QRS complex. And QRS complexes are just easier to identify because they have a few different parts and they're a lot bigger than a P wave. So shortly after the the P wave, we should have a PR interval. And this should be just a slight pause in between the P wave and the QRS complex. We don't want it too close. That could indicate some different diseases going on with the patient. Again, not something for this class. It's a little bit more advanced, but there should be a small pause, what we call the PR interval in between the P wave and the QRS complex. Next, we see the QRS complex. This represents then ventricular conduction. So it just means that the electricity or that electrical conduction is moving appropriately through the ventricles. Now, if we have a pulse, we can assess this at the patient's radial, brachial, carotid site. If there's a pulse right along with that QRS complex, that just tells us that there's also contraction going on of the heart, right? And then the interesting thing about the QRS complex is that it covers up repolarization for the atria. So just know that repolarization of the atrias are recharging when the QRS complex is depolarizing. All right, so let's identify the different parts of the Q wave, or I'm sorry, of the QRS complex. So first we have that little Q wave. So the Q wave is the first downward deflection of the QRS complex. So right in here, this is going to be our Q wave. It's going to be following the P wave and that short PR interval. Usually it's non-existent though. So if we look at this downward deflection, a lot of times we may not see it on an EKG. That's totally normal. So basically what we see is the short PR interval and it just goes straight up into the rest of the QRS complex. So again, that's not that big a deal. If we see it, it could be significant, but really it's not that big a deal if it's not there. The R wave, let's identify that R wave. So the R wave is what we see right here at the top. So we have a Q, we have our R. So where do you think our next wave will be identified? Well, the S wave is this downward deflection, and it's identified as any downward wave preceded by an upward wave. So this downward deflection is going to be our S wave. This is the R, and down here we identified our Q wave, right? So those are the basics. Those are the components of the QRS complex. After the S wave, or after that QRS complex, we have what we see on the screen here is the ST segment. So it's just a small plateau phase where it comes right back up to baseline, right? So we see that our S wave down here came back up and then it comes back to this baseline. That's just known as the ST segment. And it should be level with the baseline. If this comes right back up and it's a lot higher than what we would identify as the baseline, just kind of generally where that EKG lies, well, that could indicate some pathologies, some pretty serious pathologies. This is what would be known as an ST segment elevation. So there's different things that can cause it, different things that kind of make it look ugly on EKGs. Again, that's a little bit more advanced, but just know that if it comes back up to baseline, we have a short plateau phase. Well, it's doing exactly what we need it to do, right? It's working appropriately. Then lastly, we have the T wave. So the T wave represents ventricular repolarization. So it just means that the ventricles are repolarizing or re-energizing themselves, getting ready for that next depolarization. And earlier we had mentioned that the atria also repolarize, right? They repolarize, or they're also getting ready for that next impulse moving through, but we can't see it because it's covered up by that QRS complex. All right, so next thing we want to talk about is electrode placement. So we know that there's a few different ways that the cables themselves can be identified. And one of the nice things about our cables that we see here, we're using the Zoll or the Philips monitor, is that they're color coded, right? We see the white, the black, the green, and the red. But just know that these may not always, or it's not a general thing. They don't need to be marked in this way. So one of the other things that we may see is that they have these letter markings on them, and what these represent is right arm, right leg, left leg, right? And let's talk about one of the ways to remember placement. So one of the easiest things that I like to do is remember that my white, and I start with my white, right on the right. And in this case, it's going to be the patient's right. So if we start there, we can think of clouds over grass. So the next thing, right? If I put the white on the right, next electrode I can place is going to be the green, because we always have clouds over grass. And then on the left side, we're going to have smoke over fire. So we'll have the black over the red, right? So that left arm goes over the left leg. Obviously, if those are blurred, or those letters aren't there for some reason, we can identify that color of the black over the red. And we talked about that, right? The RALA, that we see here on the screen just represents that right arm, right leg, and left leg. So leads, we always hear reference to leads. We say, well, you know, give me the leads. Well, what we're talking about is actually the cables. The leads, talking in technical terms, is actually the view that's created when we connect two of these electrodes. So when a pair of electrodes is connected basically on the patient's body, we then can see a lead or a view. So when the right arm connects to the left leg, we see lead 2. And lead 2 is actually one of the clearest views we have, mainly because the electrical impulse starts from the SA node down to the apex of the heart, right? Which is, let's say, generally pointed down towards that left leg, right? So that's why when we identify lead 2, it actually gives us the clearest view of what that electrical movement or that electrical impulse is doing through the heart. When we connect, let's see our next one here. When we connect the right arm to the left arm, that's what we see on our monitor screens as lead 1. Again, another good view, but just so you guys know, that's actually what we're referring to when we say lead 1. And then lead 3 is created when we connect the left arm to the left leg. Cool. So now we can see we have all these different leads. We have lead 2, lead 1, lead 3. So what's going on with that green marker down at the bottom, right? That green cable that we connected. Well, actually, interestingly enough, let me go back here. This is just a ground, and what it does is it actually makes visualizing this electrical movement a little bit clearer. We still get artifacted. Sometimes those squiggly lines get even more squiggly, but that green electrode is actually a ground, same as we see with electricity in general, and it does help to clarify some of those some of that EKG rhythms that we're looking at. Oh, one other thing I wanted to mention here is also the different poles that we see here. So when the lead 2 is connected, it has its negative pole at the right arm with its positive end being at the left leg. Whereas lead 1, we see same thing, right? It's positive in lead 1. The left arm is positive in lead 1, where the right arm is negative. But the left arm is actually the negative pole in lead 3 when we're looking at lead 3 with the positive being at the left leg. So just something interesting to point out there. Now we know that we're only attaching 3 or 4 electrodes, right? If we take that ground out, we're only attaching 3 or 4 electrodes to the patient. But how many leads are we actually able to look at? If we go through our monitor, we know that we can see lead 1, lead 2, lead 3, but we also have the ability to look at AVR, AVL, and AVF. Well, that gives us a total of 6 leads or 6 views, right? Well, how is that possible? What is it that we're looking at here? Well, what we're seeing is actually a computer-generated a view basically by augmenting the voltage. So what it does is it connects, in this case, let's look at AVF, or Augmented Voltage Foot, as you can see at the bottom right of your screen there. The computer does that, it connects, let's say that right and left arm, it creates a negative pole at the top, and then our positive is going to be at that left foot. So that's how it actually creates that augmented voltage, augments the voltage, and then we can see just a little bit more, or a different view basically. Same thing goes for AVR. We have that augmented voltage right. Now in this case, it's the left arm and the left leg that are connected, and it just, in general, shows what's going on with that electrical movement. If we were to take a look at the electrical movement going this way, right? And then same thing for augmented voltage left. So it connects the right arm with the left leg and looks at the left, and then sees that all the electrical movement moving towards the left arm. So that's basically what we're looking at when we're looking at the different views or leads of the EKGs. So let's just recap. We know that cardiac muscle is unique, right? It has 3 unique abilities, which were automaticity, contractility, and conductivity. We went over some of the structures of the heart. We looked at the atria. The atria holds the SA node. At the very bottom of the atrias, we have the AV nodes, and that separates the atrias from the ventricles with the valves, right? We talked about those valves acting as insulators by only allowing that conduction through the heart, through those different sites, right? SA node to the AV, to the His bundle, to the right and left branches, to the Purkinje fibers through the ventricles. We looked at some of the waves that are produced on the EKG, right? We talked about the P wave, the PR interval, the QRS complex, the ST segment, and the T wave. We looked at our electrodes, how we're going to be placing those. We looked at the leads, or the different views that are created when we connect our electrodes, or when they're connected to the patient, what it is that we're actually looking at on the monitor. And then we talked about those augmented leads. All right, so if you have any questions, please feel free to contact me, or go back through this video. Hopefully this was clear in the way that we can now identify different things that we're looking at when we look at an EKG. So next we're going to get into EKG interpretation. So let's go ahead and take a look at that.